Okay, we're just going to get started. For those of you that have seen me present before, that you know that I have a lot of slides, so we have to get through them. So I'm just going to introduce myself. I'm Dr. George Musa. I am a medical geographer. Don't worry if you don't know what that is. A lot of geographers don't even know what that is. And yes, there are people that still study geography, believe it or not. So I am very much like an epidemiologist, except that I concentrate more on the location than the etiology of the disease. So my talk today is suicide, trauma, and injury research for with GIS. In the first few slides are going to be more about background information that we all kind of need to know a little bit before we can get into the good stuff. The second set of the sort of the latter part of the presentation is going to be more like almost like a workshop, a demonstration. Although I'm not going to be running the GIS because I didn't know what the environment in which room was going to be in. I have some screenshots that would help us navigate the system so you can see how the process would actually work. I just want to demystify what a GIS is. A lot of people like to think that the GIS is something that is unapproachable, but the reality is it's not. It's an excellent discipline, and one semester class doesn't do it, but it's very, very approachable. Okay, so overview, what is medical geography? Again, for those of you that don't know what it is, we're going to look some examples for GIS for visualization, GIS for exploration, cluster detection, and then some quick demonstrations. Medical geography uses concepts and methodologies from the discipline of geography to investigate health-related topics. Founded by Jon Snow. No, this is not an HBO Game of Thrones reference. Jon Snow, the real Jon Snow, was as he was also the founding father of modern epidemiology, where they look for distribution and determinants of disease in populations and across time. So basically, this is way before computers were even around, right? This is 1854, cholera in London. He plotted out on a map, on paper, all the deaths, plotted out the central pump, what's called the Broad Street pump. And by removing the pump, he showed that cholera was a waterborne disease. He drew concentric circles around the pump and noticed that most of the deaths were around this one pump. So he convinced the town to remove the handle of the pump, thus reducing cholera. So what is now a traditional modern GIS? You can think of Google Earth, but Google Earth or Google Maps is not a GIS. It's just a mapping place to navigate, sure. But and yes, you can turn on the satellite layers and things like that, but you can't really use it to analyze anything that occurs on Earth, much like what a GIS would do. And the traditional GIS uses layers, data layers. So every layer you can think of, you can put over on a map and overlay them on top of each other. So your base layer would be something like the population at the village level, at the provincial level, the regional level. And then you can overlay transportation lines like roads, and then on top of that, the medical services, location of hospitals, location of cases, et cetera. And then you can analyze the data, not only amongst the layer, but across the layer. Two basic forms. We have the raster on your screen that looks much like pixels of a photograph. In fact, a digital photograph is just that, is a raster file. If you zoom in close enough on a pixels nowadays, on a phone and so on, you can actually just see blobs of color. It's the same principle. So each blob of color represents something. It's great for continuous surfaces like a photograph would be, like satellite images, a continuous surface like elevation, which are some examples up there of what's called the round out of the Hudson River. You can then look for mountainous regions, the rivers, whether Georgetown is below or at sea level, things like that. The vector model, which is the more popular model, uses points, lines, and polygons to represent discrete geographic features. The points are locations, could be a city on a large map, could be a case of a suicide attempt, could be a case of a car accident or car collision. The lines are connections of dots, and it's basically the road systems, the rivers, trains, buses, airplane routes, etc. And then when you enclose all the lines, or connecting all the dots, you create polygons, which are great for discrete entities like administrative boundaries, the boundaries between the regions across Guyana, country boundaries, continent boundaries, etc. The disadvantage of the polygons is that you're assuming that what you're looking at across the entire, so say that you have population, as we'll see in a bit, you're assuming that the distribution is equal across the entire polygon. Whereas in raster, you can click on a pixel and get at least an estimate as to what the population is at that specific spot. Okay, GIS for visualization. The most basic thing, where are the populations, which areas have the highest rates of diseases, things of that nature. This is New York City. For those of you who are not familiar with New York City, and it's at the census tract, which is a sub. You can think of each borough like I should have labeled them, I apologize. Each of the large greenish boxes that have the dark outlines, each of those are counties. And you could think of those as regions here. So New York City has 5 boroughs or 5 counties, or you could think of them as 5 regions. Then sub-region, where here in Guyana we would have village or a voting district. There in New York City, we would have a census tract, which is designed to house X number of people. This is the percent of Guyanese among the census tracts from US Census 2019. And we can clearly see in the reddish areas that the Guyanese population are basically in the Queens area. And again, I apologize, I should have labeled the polygons, but that is the reddish, the really darkish reddish areas are in Queens, and the region just below it, or the borough just below it, is Brooklyn, which has some Guyanese populations. But apart from that, the rest of the regions, there's not that much. This is an example of a trauma exposure research where what we're seeing is the yellow to red boxes are the number of residents that were exposed to the 9/11 attack from a registry of respondents. And the bluish sort of overlay is the flooding from Superstorm Sandy, which occurred several years ago in 2012. And so by overlaying the population polygons by the water damage, by the flood zones, we can predict how many people of that population were in harm's way or were affected or were exposed to a traumatic exposure. Now, the challenge is, as you see in the lower reddish box, that, I wish this thing had a pointer. I don't know if it does have a pointer. It does not have a pointer. The reddish box, that is lower Manhattan. You have to assume that the population is evenly distributed across that entire polygon, which we know is not correct. There could be a park in the middle. There could be all business areas, and the residential areas would be in one small spot. But it's the best that we have. This is cases of suicide and suicide attempts in Tajikistan in a project that we did back in 2010. And you can see that the populations are in the boxes are the range of suicides and attempts. And they're aggregated to the kilometer just to show concentrations or possible clusters of suicide. Now you'll see Kujan, which is that red dot in the middle, that gets highlighted. Why does it get highlighted? Because it's the highest number of cases. But what's the problem with that? Well, the highest number of cases may or may not be in the area that has the highest number of people. So without looking at rates, you can't really tell that from this map. This map could be misleading to some, don't read it according to how it should be read. So for example, here's suicide deaths in Guyana in 2020. The deaths map shows that region 4, which is where Georgetown is located, has the highest number of cases. That's true. Regions 3 and 6 have the second highest. Regions 2 and 5 have the third highest, and then it's fairly green in the rest of the regions. But if we control for the population, for the underlying population, and compute a rate per 100,000, we see that things change drastically. Region 4, Georgetown area, is no longer, it's the third highest. You see it is in yellow. Yet regions 2 and 3 immediately light up as red as the highest. Regions 5 is now the third highest, the second highest, and region 6 remains the second highest. So region 6 not only does it have a large number of cases, but also it also has a high rate, which those of you that know the situation of suicide in Guyana know that it borders Suriname, and in fact, the opposite side of that river in Suriname also has the highest rates of suicide in Suriname. So, which is something that's interesting. Is it because of migration across from Suriname to Guyana, back to Suriname? Is there something in the environment? We don't know, but that's something we hope to look at one day. GIS for exploration. Where are the health services located, and are health services located in optimized locations? If an outbreak were to occur, COVID, right? What is the capacity of these services to handle it, and where can we optimize the locations? This is the location of hospitals, medical schools, and licensed mental health facilities in New York City. I wanted to do the same map for Guyana. Unfortunately, the health services are not what's called geocoded, or they're not plotted on a map. So it was impossible for me to produce such a slide. We're working on that, trust me. I met with the Bureau of Statistics yesterday, and they're working on many different GIS layers, which is great. So you can see the reddish, orange reddish locations. Those are the high concentrations of school children. The dots that are scattered all over are the health services, and the circles that I just drew on top show that there might be areas with high concentrations of children, yet no health services in New York City. And yes, this is New York City. You would think there's health services everywhere. The reality is there isn't, okay? This is an example from Dr. Chang-Po Huang in Taiwan, he was looking at if there was an epidemic that was breaking out in Taiwan. Their brilliance, they were ahead of the game, ahead of COVID. I'm actually curious to find out from him later, he's on here today, if in fact they use this model to identify where, how to use it for COVID. But they mapped out all of the health facilities in the Changhua district, and they were able to, and they knew what the capacity of each of the facilities was. They were able to determine, where in the mountainous regions, that is in the larger map, it's all reddish. Those are the areas that are lacking coverage. How could they expand the coverage by including different facilities in different places? And the smaller maps are different scenarios as to which one produces a better coverage to cover the area for health services. So again, it's not simply just mapping things. It's understanding and analyzing, exploring of phenomena that happens on Earth. Okay. Disease for surveillance. This is something that we've been pushing here at the conference since day one, and we truly believe that that we need a disease surveillance system here, not just for suicide, not just for mental health, but for all diseases. It's imperative that we have the right data at the right spatial resolution so that we can help and we can make an impact, and we can, if we have timely data, we can prevent what are known as suicide clusters, where one person, a young person in the village dies by suicide, then you have 2 or 3 others that at least attempt. simply because they knew them and they said, oh, well, if they can do it, I'll do it too. If we know that that event happened, immediately we can send folks from the mental health unit to respond to make sure that the others in the village are not also at risk for suicide. New York City syndromic system was established back in the early 2000s. And basically, I'll skip this, this slide here, it's just too much words. Basically, they get reports every day from emergency departments from all over the city. And they get them via the web, but they're text. They're just, and we're not talking about how many people had a disorder, how many people had operations, or how many people came in with a car collision. It's more about symptoms. That's why it's a syndromic surveillance system. So, you know, the person, you know, line by line person that came in reporting fever, reporting a sneezing, reporting a cold, a headache, and they also obtain the gender, the age, their zip code, their postal code of where they reside, or their neighborhood level as to which neighborhood they reside in. And that data gets read into the system every day. And the computer system analyzes all the words that are in the system and then predicts, running what's called the scan statistic, can identify geographic areas and syndromes that are beyond just randomness, because they're either too close in space, too close in time, or a combination of the both. And this is an example in 2002 where they found some residential-based signals, in other words, from the community, based on their zip code, that they were just too close in space and time. And you'll see that in the northern Manhattan and the southern western side of the Bronx lights up, that it was for influenza. Again, this kind of system has been used for many, many years. And we hope that one day we can put something in place here in Guyana to address these kinds of things. We were looking at probably an SMS system, because obviously New York City has a lot more internet coverage. Here in the interior, that may not be so well, although WhatsApp is used widely. We're thinking of maybe an SMS, that you send an SMS to the system, and the system analyzes the data and reports possible clusters. Okay, I know I'm going fast, and I'm sorry, but I really want to get to the fun stuff, okay? Let me see what I'm doing on time. Perfect, okay, fantastic. Okay, so I was a geographer. I have to show this is basically our only rule, right? Is Toblers Law of Geography, or first law of geography. Everything is related to everything else, but things that are closer in space are more related than things that are further apart. It's the basis for a lot of the work that we do. And it's the basis for all GIS analysis, and in essence, okay? This is an example of arsenic in agricultural soils in Changhua County in Taiwan. And these are just dots, right? You can see that they're all equally spaced. There's a missing dot because there was bad data. But each of the dots was collected with a GPS receiver, and they collected soil samples, and they sent it to a lab, and they determined the level of arsenic in the soil. And then that level was recorded onto an Excel with the coordinates. And then we can plot it, and then we can change the symbology or change the size. So the larger the dot, the higher the level of arsenic. And you can immediately start to see a pattern. At least I see that pattern across the areas where you can connect if you connect the larger dots, you see that maybe there's a river running through it. Once we do what's called an interpolation, and this is a very quick and dry interpolation, we could see the reddish levels, and we can see that pattern even more clearly. And that shows that maybe there's something going on here. Most likely, if you know topology, there is a river that runs through there, and there's a valley. As heavy metals settle, because they're heavy, they settle down to the floor of the river, and thus the contamination has higher concentration among those areas. So most likely this is what's happening here. And sure enough, when we overlay or put the river layers on top of it, you can clearly see that there is, in fact, a river running right through the dots. And then we can also overlay industrial facilities that may or may not be the source of the pollution, of the arsenic pollution. Unfortunately, the soil samples were only obtained in areas that could be obtained, that were exposed to the ground. This is right by the city, so they could not obtain soil samples anywhere else from this area, except for the area that we were looking at here. Okay, now, so what's the next level? Let's talk about cluster detection. In New York City, they used to identify clusters of West Nile virus. They ran a system. Every day they were collecting the number of dead crows found all over the New York City. People were calling it in, reporting it, much like surveillance system. If you think about it, texting, you can call it in as well. And every day the system ran a space-time analysis to identify if the dead crows were too close in space and time to just be due to randomness. So in other words, they didn't wait until the crows were tested for West Nile. They said, forget it. If it takes too long, it's like the initial days of COVID. It was taking too long for people for the test for COVID to come back. It was taking weeks, sometimes a week to 2 weeks in New York. I don't know how long it was here. Now PCRs are down to 2 or 3 days, but even 2 or 3 days might be too long, right? If you try to prevent an outbreak, if you know the symptoms and you count the number of people that are reporting with those symptoms, and it's too close in space and time to just be due to some random chance, there's a highly likelihood that there is an outbreak of COVID. And in fact, when they ran this analysis in 2001, and they found this was you could kind of see the reddish, brownish areas in that Staten Island. That was a concentration of dead birds that was too close in space and time. And sure enough, a few days later, a human case of West Nile was identified right smack in the middle of the cluster. So they were able to predict where a new case of West Nile would come. Same thing that could be done for COVID. Same thing that can be done for suicide. We can if we can identify at a syndromic level the reports from villages or reports from different areas as to different symptoms, we could identify people that are possibly attempting suicide, and we can then prevent a cluster from happening, or at least one other person from dying by suicide. Same thing can be done of injuries as well. Okay. Okay, so what about trauma research? This is a New York City study that we did in 2002. As a representative sample of school students in New York City across all public schools. And we mapped out the city, the reddish area, that is where the ground zero area was. That's where the World Trade Center towers were. The green dots are the schools. The orange dots, the orange polygons, I should say, are areas that we felt were at high risk for trauma-related mental illness in the school children. And what we were expecting to find is something that Pinus, Pinus was one of the ones that first analyzed PTSD in any type of spatial domain. This is after a 1984 school shooting in California. And what he found was a distance decay of PTSD. So he plotted out PTSD by distance to the school. They were either on the playground, in the school, on the way home, in the neighborhood. So the shooting was on the playground itself, at home, absent, or out of the vicinity. And he noticed that the rates of probable PTSD decreased the further out you got. Much like when an earthquake happens, when a storm happens, those closer to the epicenter of the storm, those that are closer to the epicenter of the earthquake, are at more risk for physical injury, as well as trauma-related responses. So the further you get away, the less the trauma should theoretically, both physically and mentally, impact you, right? But what we found when we plotted out the responses of their answers for the 8 PTSD items in the questionnaire, we found that yes, things like harder to keep mind on things did show this pattern as the further you got away, the lower the response rate was. But things like having a nightmare actually went up. The further you got away, the higher the response rate was. In fact, any PTSD symptom, the higher it went, slightly higher. Okay, some of them went up and down. Some of them started high, went down, some went back up high. There was a very different pattern, and even when we combine it together, we still didn't see a pattern. This is a logistic regression model looking at distance related to the trauma. And what we found was that those attending a ground zero area school were actually somewhat protected against PTSD. Now, that's a very controversial statement. I just said before that those that were closer to the epicenter, those that were closer to the event, had higher chances of having a stress-related illness. Well, here it's showing that it's the opposite. But if you look at the confidence intervals next to it, you'll see that it's a non-significant finding. In other words, it doesn't really have an effect here. It doesn't mean that it's higher or lower. It just means that we can't really tell. But if you notice that the exposure items at the bottom, having a direct exposure, a family exposure, prior trauma, and high TV exposure, were the highest predictors of a student having PTSD or probable PTSD. In fact, they were all high risk factors. 1.89 odds ratio for prior trauma was the strongest was the predictor. That was one of the interesting things, because it's not something that was really well understood at that time. Also, TV exposure. Kids were developing, we had reports of kids developing PTSD, or at least exhibiting trauma-related illness responses from places like in Japan, believe it or not, due to 9/11, because they kept watching it on the TV, they kept watching it in the news. Well, that's also one of the reasons why media coverage of suicides needs to happen very, very carefully. We understand that it's news, but the glorification of suicides actually has been shown that increases suicidality amongst populations. So TV exposure, yes, you can get PTSD from just TV exposure. Potentially, anyway, at least some related symptoms. Distance could be, and no matter how we looked at the distance, whether it was straight line distance or we broke it up into the different circles that you saw before, we found no evidence that distance was playing a factor here. And again, it's a representative study. So what else could it be? Well, maybe it's the way we're measuring distance. Maybe Euclidean distance or straight line distance could be was used. Maybe we should be using Manhattan distance or even transportation distance to see if there's an effect. When we check the other types of distances, really, again, there was no difference. So what else could it be? And this is what the use of GIS is so fascinating. You can think outside the box. Is it the exposure to the smoke, the plume that was over New York City, which is quite large, that emanated from the towers? Is it, could you see the towers fall from your neighborhood? Is it your neighborhood socioeconomic factors? Is it neighborhood quality or safety? These are all the kind of things, if we have the right data, we can look at. This is the satellite image of the plume that emanated from the ground zero at the time. And you can see that the plume was quite large and and it actually moved. And so we could see which students, which postal codes, which neighborhoods, which schools were directly under the plume of smoke, because a lot of the students reported that they were in or near the cloud of smoke, when in fact, they were in Brooklyn, they were in Queens, they were far away from ground zero. Why is that? It's because their perception of being in harm's way overrides the actual physical location. Much like with the TV coverage, their perception of being in harm's way overrid the fact that there was no possible way they were going to be harmed by 9/11 because they were in Japan, they were in New Jersey, they were upstate New York, etc. Okay, but it's our perception. Um, these are the whether or not you could see the towers from the neighborhood, and the proxy you can use is whether the building's rooftop had line of sight, or whether the buildings whether the street level had line of sight. We can't see in everybody's windows, of course. We don't know how, we could look at how tall the building is, and by using the height of the building, much the same way cell companies establish cell phone towers. They look to see where the mountains are, where the high buildings are, where is the best location to put a new cell tower that they can have the most coverage in an area. We can take that same approach and flip it so that we can say, where in the area can we see the towers, the rooftop of the towers? And you'll see on the view shed analysis, you see all the reddish areas. Those are the areas that you could actually see the towers from. And then we can aggregate that to the postal code, to the zip code, to the neighborhood, as defined here. And then we can see the areas of red, the areas of yellow, and the areas of green. Green, you can't see it. Oranges, you can see some of it. And you can actually see that there's some areas that are very far. In fact, the areas where we saw some of the Guyanese concentrations, or close to the Guyanese concentrations in Queens, you could actually see the towers because of the building geometry and everything else. Well, what about neighborhood, socioeconomic status, and quality and safety? If you look on the left, you see the socioeconomic status, you see the areas that are red are the lower income, the areas that are green are the higher income. On the other side, the quality safety index that we've been constructing. In fact, the paper was published this past June, looking at different neighborhood level indicators of the 8 psychiatric disorders that we assessed in this study. We can actually see the high red areas where there's high crime and low quality. And yes, there is a large overlap between SES and the quality safety indices, but not everywhere. For example, the yellow areas of Upper Manhattan versus the orange areas of Upper Manhattan in terms of the SES, they don't overlap 100%, which again, the more information that you have, the more we can, the more in-depth our analysis can be. So quick findings: after controlling for exposure, the odds ratios were between 0.55, which is a protective against alcohol use disorder, versus 1.55, which is a risk factor for agoraphobia, in low and intermediate low SES neighborhoods, respectively. So low SES protective against alcohol use disorder. Interesting. Maybe it's just they can't afford it, right? Again, alcohol use disorder, protective, 0.50 versus 2.54 for agoraphobia in low quality neighborhoods. So again, if a student lived in a low quality neighborhood, they were at high risk for developing agoraphobia, and they were protected against an alcohol use disorder. There were, again, a reverse picture for agoraphobia, where it's actually protective in low safety neighborhoods. So those that were in low safety neighborhoods were actually protected against agoraphobia, versus and separation anxiety was also protected in low neighborhoods. That is another controversial point, because if you think about it, agoraphobia is the fear of going outside. So if you're in a low safe neighborhood, in other words, a high crime neighborhood, is it you're staying home because you're agoraphobic, or is it because you're just afraid to go outside because it's a bad neighborhood, right? So more work needs to happen in looking at that. When you combine all the measures of SES and quality and safety into one measure of neighborhood disadvantage, we found that a similar pattern, alcohol use disorder, was protective in the low disadvantaged neighborhoods, in the high disadvantaged neighborhoods, and 1.36 or a risk factor for separation anxiety disorder. So this suggests that, yes, in fact, neighborhood factors are important in social determinants of child and adolescent mental health, even after the aftermath of a mass trauma. We can take that same approach here, looking at COVID responses, right? If we have the right type of data. This is just an acknowledgement for all the work, for all the people that, okay, now the fun stuff, okay? Let me just check on myself on time. Perfect, plenty of time. Okay, so disease surveillance. So let's take a look. So these are dots, and let's just play a game, okay? These are dots that are scattered all over an area. We don't know what it is, all the little dark blue dots. And the pinkish fuchsia circles are some hazards that we're interested in seeing if there's a relationship between the points and the pinkish dots. And we highlighted one in the middle that's green just to identify it, because there's one that seems to be in the middle. And we're just trying to figure out what's going on here. So what we can do is the classic concentric circles, where we draw circles around all of these hazards and then count how many points are in there. The problem with this approach is that you'll see that a lot of these circles overlap, and some of these circles have gaps in between where there's no real coverage. So how do you determine which dot belongs to which hazard? Well, there's a better approach, looking at Thesian polygons, where it's basically the best fit circle, although it's not a circle. You basically you separate the hazards and you connect the dots, and you come up with polygons that don't overlap, that don't have gaps, and then you count all the points inside these polygons. And what do we find? Yes, in fact, that polygon that has the green dot has the highest number of cases. Okay, as you see, it's all lit up in red. So something is going on here. Something related to this one hazard is happening. We can actually also compute the distance of all the points to each of these hazards, and especially that one green hazard, to see if there's that distance decay. And we do see that. If you see the blue bar graph, you do see that distance decay happening. Okay, so what could this possibly be? Some of you probably already guessed it. In fact, it's John Snow's cholera on Broad Street in 1854, London. And that green dot that we were talking about is the Broad Street pump. Those dark colored dots were the deaths due to cholera, and the P's that you see on the map were actually the pumps, the other pumps besides the Broad Street pump. So an analysis that John Snow did in 1854, we've replicated with modern GIS and come up with similar findings. Again, if we have the number of attempts of suicide, number of car collisions, number of any types of injuries due to falls, due to slippage or something, we can always analyze this type of information. Demonstration 2, road collision in New York City. Road collisions here in Guyana is a very big problem. And if we have the right kind of data, we can actually look at what's going on. So these are all the different road collisions in New York City in 2020. We're very, very lucky. New York City has tons and tons of data that is publicly available. And you can see the scattering of car collisions in New York City. Yes, there are a lot of them. There are just thousands of them, right? But that's fine. The GIS can handle it, right? So here are all the different dots all over New York City. And then we want to know where the collisions are. Well, we can do an aggregation to the polygons, as we've done before with the zip codes. And here is to the police precincts. And we see there's some areas in red that are highlighted here. Again, very close to the Guyanese population that we saw before. The challenge here is that the polygons here, again, you have to assume that the distribution of the collisions is equal across the entire polygons, which if you have the actual locations and dots, this is not the best approach. Now, governments like this approach because it's easy to report.
It's easy to put on a slide and to report, these are the number of cases of COVID, these are the number of collisions in the region, these are the number of deaths by suicide in the region or the village, etc. But as a medical geographer or a spatial epidemiologist, we want to get it to a better level than just a coarse village. We want to get it down to as close as we can to the location. So by using what's called a kernel density estimation, and there are many cluster algorithms, this is probably the easier one, kernel density estimation, we can estimate how densely are these dots and where is the most dense concentration of these dots. And here's the result, and I ran a real quick one, and you can clearly see these dark colors, thus where there are a lot more collisions in close proximity to each other. And sure enough, the highest concentration, when you look at the data, when you look at the attributes of the results, you find that there's an area in the Bronx, New York, that has the highest collisions in 2020. Well, you can then zoom in to that area, and you can see it's right by the Cross Bronx Expressway. And those of you that know New York City, you know that the Cross Bronx Expressway, we like to call it the parking lot, because it's usually, that's what it is. You're stuck in traffic because there's been a problem. And the accidents, the cluster is just off an exit ramp from the Cross Bronx Expressway. Now, I was in a table discussion a couple of days ago with Professor Cummings from University of Guyana, and he was talking about where can, how can we identify there's a road in Guyana that's notorious for collisions, and how can we tell what it is? Well, with the right information, you can. There's a very good chance that there's something going on in this exit ramp. Maybe it's too short. Maybe and you can actually kind of. I wish again I had a pointer, but you can see that that my mouse. There's no mouse here either, but you can see that right off that red line that feeds into the red box. Maybe that exit ramp is too short, and maybe there's some collisions right off of that exit ramp, which causes a backlash into the Cross Bronx Expressway, that's causing all this horrible traffic. Could be. We don't know what it is. Similar to the road collisions here in Guyana, amongst that one notorious road, maybe the engineering needs to go in there and assess what's going on. Maybe they could put road bumps to slow the traffic down. Maybe people just taking the turn at too high a rate of speed for how it's defined. And that's what I have. And I made it just in time, which is fantastic. I hope I didn't go too fast, but I'm willing to take any questions. I just have to stop this presentation. Yes, I'm my own IT person today. So if you excuse me for a second, I'm still here. I haven't gone away. I'm just trying to open up the QA here. Let's see if there are any questions here. No questions on the screen. Does anyone have any questions from any of the participants in Zoom? Are there any questions at all? So, again, if you're interested in learning GIS, University of Guyana does teach GIS in the Natural Sciences division. It's widely used for geology, widely used for mining, widely used for things like that. But it can also be used for mental health. It can also be used for non-communicable diseases, and obviously used for infectious diseases. But think outside the box. Think of what else you could look at in a spatial domain. Now, whether the data is available for Guyana, they're working on that, and I've been promised that. Not next year, because the census of this is this year, but in a couple of years, Guyana will have similar geographic boundary layers, road layers, and things like that that can be used. Thank you again, Chinwe. If there are no questions, we can just wrap up here and get ready for the next sessions. Thank you, everyone, for attending, and thank you, everyone, for being patient. Thank you. Thank you again. And please check out the other sessions in our wonderful conference. Today's our last day, but we are gonna have this every year. So hopefully next year we can do more of these wonderful sessions.